Okay, welcome back to Lesson 4, Part B. And we're back to Joe, and we're on his first of our three triple jumps. So these are kind of simplistic questions, but his working diagnosis is hypertension. And the question here isn't whether or not he has hypertension, because he does. We've staged him as stage 2 hypertension. But when we talk about differential diagnosis, we want to differentiate between primary and the older term being essential hypertension, and secondary hypertension. And we'll talk about that in a minute. As far as the ASCVD risk calculator, sure, we would like to do that once we have some more information. We're going to look at that a little bit later. And in his case, it doesn't really matter in terms of whether or not we're going to start treatment. But say his blood pressure was only 140 over 80 or 90, we might take a look at that, and if he had less than 10% risk of cardiovascular disease in 10-year risk, we would say we might hold off on treating him right away with medications. But in his case, of course, he has stage 2. So we are going to go ahead and treat. We talked already about the best choices of medications, the first medications being thiazide diuretics, and then an ACE inhibitor or ARB. In his case, we're going to go calcium channel blocker if he was black. He's not. He's Caucasian, so probably ACE or ARB. We do want some lab tests at this time. There are several things that you may want to consider, but in terms of very simple things at the very beginning of therapy, if you're thinking of drug therapy, which we are, we would want to take a look at his renal function. And also to see if he has comorbidities like diabetes. So we could do a chem panel or a comprehensive metabolic profile. Additionally, at some point soon, we'd want to have a cholesterol to take a look at other risk factors. And we'll talk about that a little bit later. There's also some other things we want to take a look at because we might want to consider a diagnosis of secondary hypertension. In his case, not particularly high level of suspicion, but we would, if he was a child, have a high index of suspicion for secondary hypertension. In children, we measure blood pressure by percentiles, very similar to their height and weight compared to the similar children in the population. It is weight dependent. Obese children do tend to get hypertensive, and sometimes after we check a few things and make sure that they are not dealing with a secondary hypertension, we will simply treat them with weight management before we get into drugs. So they are a population where we would talk about secondary hypertension, mostly renal in the terms of children. That's also true among adults, but children, it's almost always renal. With an elder, when we see a new onset of a rapid rise in blood pressure, we do get suspicious of secondary causes. Now, keep in mind that, of course, as we age, our blood pressures go up, and they go up in a gradual trajectory. Of course, if the blood pressure hadn't been taken in 15 years, it might seem sudden, but it really probably is not. So there are multiple causes, some intuitive and some not so much. Here is a comprehensive list from the ACC-AHA document. And the things that you see at the top, you could see that there's possibilities in our case for even things like obstructive sleep apnea, if he is a large man with a large neck circumference, and drug or alcohol induced. And actually, if you can think back to the case, he's on NSAIDs or nonsteroidal anti-inflammatory medications, which is one of the drugs that can cause elevated blood pressure, along with some other common over-the-counter drugs like antihistamines. Decongested medications that people use for stuffy nose, and alcohol. And he is drinking a fair amount of alcohol, more than recommended, which for his age and gender would be 2 alcoholic beverages daily. So when we think about his medication choices, so let's just assume we've ruled out the secondary hypertension idea, that we may want to get rid of his NSAIDs out of the picture. That is probably a reasonable thing. We certainly want to do a couple of other things in terms of tobacco use, which also increases blood pressure, kind of more on a temporary basis, but tobacco use does cause cardiovascular disease, and so adds to his cardiovascular risk greatly, and reduce his alcohol use, and of course increases physical activity. But let's talk about the drugs. When we're prescribing medications and making choices, we want to consider, of course, mechanism of action. And mostly we go back to our physiology and think about the effect of the medication on the blood pressure equation, because we know blood pressure equals heart rate by stroke volume times peripheral resistance. We'll talk about that a little bit more in a minute. We also want to consider cautions that might be in place because of the patient's underlying condition. We want to think about monitoring. How much do we need to do in terms of lab monitoring? We want to think of common and worrisome side effects or adverse reactions. So common side effects, again, simplistically, things like diuretics. We know that the people are going to be having frequency of urination. We talked about that some already in our patients with who are in jobs that require them to be on the job for 4 hours, and then having to step away to use the restroom is not acceptable in that 4-hour block. So sometimes diuretics are not as helpful. And then worrisome things like severe effects on certain lab parameters and so forth that were going to make us stop the drug. I often think I divide these between the common things that bother patients but don't really cause alarm for us, but they're going to make the patient stop the medication, such as frequent voiding, or in the case of an ACE inhibitor, they may develop a mild dry cough, which is non-pathologic, but sometimes just bothersome, and patients don't want to have that, so they want to stop the medication. We also want to consider non-pharmacologic treatment, and we'll talk about that some more. So again, the equation, very important, and we often have a combination of effects. Let's take a look at one area where we're going to offload fluid and reduce the volume, as well as doing some other things. So this is just a cartoon of the glomerulus, and of course there are zillions of them in the kidney. And you can see here that the various diuretics work at various places along the line of the glomerulus. Let's just start with one drug that is not generally used as first line for hypertension, but is used later on in congestive heart failure, and that is a loop diuretic, or furosemide. Now, furosemide is one of those drugs that is very potent. It takes off a lot of fluid quickly. It's great for failure. Not used as much for hypertension because it's a little bit of a big gun and a little bit early. Then we see the thiazides, and we have a couple of them that are examples. I listed hydrochlorothiazide first, HCTZ, mostly because it's more commonly used out there. It's not necessarily the best choice. You can see in the guideline that the preferred drug is chlorthalidone, which is an older drug, isn't horribly expensive. You can get it for about $16 a cash price, and it's probably on most formularies for generic. But hydrochlorothiazide is cheaper. It's only $4 for a month's supply. And you lose a little bit of potassium as well as sodium and chloride salt when you take out the fluid with the diuretics. Then there are potassium-sparing diuretics. Aldosterone is one example, but we don't see that used as much, certainly not for hypertension. It is used in some special kind of cases. We'll see it used in heart failure as well as cases like polycystic ovary syndrome for other reasons. But you do need to understand that potassium is one of those things we're going to monitor because, as you know, we need to keep that in a fairly narrow range in terms of being cardioprotective, because too high or too low can be dangerous for patients. It's interesting that early on, before a person gets into any kind of renal failure, we have all this, but a person in renal failure, of course, will have a lot of potassium on board, and we have to be extremely careful. Now this is, again, just a diagram, very simplistic diagram of the renin-angiotensin system where a lot of the drugs that we use work. As we recall, the liver creates the angiotensin, angiotensin 1 goes to lung, creates angiotensin 2, goes up to the brain, ADH, the antidiuretic hormone goes down to the kidney, and thus creates this, balance and creates vascular smooth muscle control throughout the body. Because as we know, we need blood pressure to survive, but this keeps everything in a kind of balance. So drugs that work in this system include direct renin inhibitors such as aliskiren, but that kind of medicine is, they're newer, they're much more expensive than the ones who work further downstream, and they are more potent, but you will not see these used in great amounts in any of the protocols. So I would kind of not worry about that so much, but I want you to understand that there are drugs that work at this level. Then there's the ACE inhibitors, and these, we call them the ACEs, and they end in the pril drugs. Lisinopril is the model drug here, and the reason for that is it's considered most potent. It's also the one that lasts 24 hours, so you take it once a day, it actually lasts that length of time, and happily it's on the $4 list. Down here, the angiotensin 2, the ARBs work here. The angiotensin, I think it's reuptake. And blockers, like losartan, again on the $4 list, and a great choice if you want to use an ARB. Remember, it's ACE or ARB. It is not ACE and ARB. You never combine the two. Calcium channel blockers are, you know, pretty. It's actually a great name because they are blocking the calcium channels in the cardiac muscle. So we get a really great reduction of blood pressure, and it can be done fairly quickly. And when you use parenteral forms of, say, nifedipine, you can really drop the blood pressure quickly. So these are pretty potent. They're the most potent of the antihypertensives. And if out in the community, if we want to get blood pressures down, we use verapamil. There are cheap forms of verapamil, but they have to be taken several times a day. That is a tough one. The amlodipine, which is a subclass, a different subclass, has a side effect of causing some edema, so we're careful about that. Although it is not considered dangerous edema, and we don't treat it with medications. We say use TEDs, not meds, TEDs being elastic stockings. These drugs reduce heart rate, and although there can be some reflex tachycardia with nifedipine, they reduce AV conduction and reduce cardiac contractility, so they reduce that stroke volume. In terms of beta blockade, which is other drugs which again are not first line, but may be out there, and we like to use beta-1 selective drugs. Again, 1 heart, 2 lungs. Remember that from patho. So we use these to decrease the force and rate of heart, and they also decrease renin secretion some, which is a nice added side effect. If we end up with a non-selective beta blockade, we also will increase airway resistance, which we don't like with our folks with chronic airway disease like COPD. But propranolol, interestingly enough, is one that we use for other reasons, mostly for migraine prophylaxis and so forth, because it actually has a small effect on increasing vascular resistance. So it can be a useful drug for other reasons. I'm going to pause here, and you can think about your next step for Joe on jump number 2, which is going to be part C of the lecture. Thank you.